Good morning, everyone. Thank you for coming. We're here to do some training today and pass along some important information about our annual survey that we had back in February, believe it or not. It was back in mid-February when we had a team of surveyors come through for our annual licensing survey. And while they were here, like most years, they'll find some deficiencies, some things that we needed to address along the way. However, this past survey visit, they found a deficiency, one in particular, that was more serious than we've normally had in the past. And so it had to do with pressure ulcers and wound care and so forth. And so as a result of that particular tag, the surveyors are going to be coming back for a revisit, which is very different from what we've had to do in the past. So what we're doing here today, and really my purpose here today is just kind of welcome you all here, and then we've got a series of speakers that will be following me to talk about some of the different tags in addition to the one about pressure ulcers, but information that we're trying to get out to all the different staff members because it's very, very important. So like all surveys, we had to put together plans of correction and ways that we're going to address the different citations that we'd gotten through the survey. And so the purpose of today is to kind of go through each of those different tags so that everybody really understands what's going on and why we're doing what we're doing and how all of the staff are going to be having a part in how we address the plans that we're working on. This year it's a little different also because we're videotaping this in service, and the reason for that is because we really want to ensure that everybody on all different shifts, on all different days that they're working, whether you're full-time, part-time, per diem, folks all across the board are getting the same information that you're all going to get here today. And so we're expecting the survey team to be back in probably 2 or 3 weeks. We're looking at probably the first or second week in April, so there's not a tremendous amount of time. And again, we're here to kind of pass along important information that you're going to be able to take and apply in your daily work to try to help us prepare for that revisit. So one last thing I'll say before we turn it over to some of the other speakers is the fact that while we're preparing for this license resurvey, we're also really focusing on the fact that this is just one step along the way. There's so much more that we want to accomplish beyond the resurvey. We need to clear this first hurdle, but then beyond that, there's still a tremendous amount of work that's going to help the gardens become better and stronger as we go forward. So it's a challenging time for all of the staff at the gardens, but it's an important time. And I think in the long run, we'll be able to look back at what we're working on right now and say, hey, this was a good thing for us because it's made us better going forward. So thank you for your attention today. And again, you'll be seeing some different speakers come through after I'm done. And we're going to turn it over to our next speaker, who is Christine, who will be talking about our first tag under dignity. So thanks.
Hi, my name is Christine Morillo. I'm the assistant administrator at the Gardens. And there are a few tags that I just wanted to touch on or deficiencies that we need to make sure everybody is aware of. So part of the regulation is that the results of our state survey are public knowledge and need to be available to our residents and guests. So we have the state survey results in a binder at the front of entrance of the gardens. And there are signs posted in strategic places around the building letting residents and visitors know where they can find that book. It's also important for you as team members to know where that is and to be able to answer the question if someone asks you, where can I find those state survey results? So it's in a binder at the front desk, right at the entrance. One of the other areas is education, and continuing education is something that's important for all of us as times change and we need to keep learning. One of the regulations is that every CNA is required to have 12 hours of continuing education each year. And we do that education in a number of different ways. We have computer-based learning modules that are assigned to us throughout the year. We have education in things like skills fairs and return demonstrations, and we had that just recently. And we also have education done through team huddles and topic-specific information that's done out on the floor or in a group meeting. All of those are important ways that we learn and gather information. So when we ask you to finish your computer-based modules or to attend a meeting, it's important that you do that, and it's important that you get credit for that. So please remember to sign in, and we thank you for participating and continuing your learning and your growth at the Gardens. Another way that we learn is through our annual evaluations. We recently asked all of you to do a self-evaluation in the months of January and February so that you could tell us how you thought you were doing in your position. All of your supervisors are finishing up their work, reviewing your evaluations, and getting ready to present those to you. As part of that, we want to present in areas of weakness a way for you to improve, and those are performance improvement plans. This is, again, another way for you to learn and grow in your position. So please understand that this is something that we do and it's part of our policy, and be on the lookout for a time with your manager to go over your annual performance review. All right, and I think our next speaker is Riss Bowens, Director of Nursing.
Hi, I'm Riss Bowens. I'm the Director of Nurses here at the Gardens. I think most all of you know me. If you don't, by all means, stop me in the hall and introduce yourself. I'm going to touch on 3 topics today. The first is gait belts, the next will be dignity, and the third will be the shower schedule. So first, gait belts. Gait belts are a part of every CNA's uniform in this building. They're to be used for any transfer of of a resident with non-weight-bearing status, or anytime they're deemed necessary for the safety of our residents. So don't be surprised if I say, where's your gait belt? The next I'll talk about is dignity of our resident. The actual tag reads that a facility must promote the dignity of a resident that either maintains or enhances their individuality. That tag can be violated by such things if my clothes are out of order, if I'm not shaven, if my fingernails aren't kept clean, if I'm eating in the dining room and someone's yelling across me or talking over me. It can also be violated by standing while feeding. So kind of rule of thumb is if you wouldn't do it at your dining room table, don't do it at ours. So with this, we ask that all people respect dignity of our residents. If you see someone with their glasses on and they're crooked, by all means straighten their glasses up. The next tag is our shower schedule. And our shower schedule, the actual tag reads that if a resident is unable to maintain their ADLs or activities of daily living, we'll do it for them. So that means that if we need to groom them, if we need to make them presentable, if we need to give them oral hygiene, brush their teeth, wipe their mouth, that we're obligated to do it for them. So with that, we have revised the shower schedules for our residents to be more easily accessible. And with that, on every unit, there is an assignment book that will tell you what day of the week your resident gets a shower. If they do not get a shower, you're obligated, all of the staff is obligated to document not only in the nurse's notes, but in Care Tracker that it's been refused or why it wasn't given. But if they don't get a shower, then they need to have a bed bath daily. Thank you.
Hi, Gardens family. I'm Jessica Coleman, Medical Director, Gardens of Warwick Forest. Just like you, I'm a member of the Gardens family. And like you, I want us to have a good one. Part of being a good family member is communicating well. One of the ways I communicate is through physician orders. If you ever see or hear an order that you have questions or concerns about, please ask one of your provider family members. This will help us have better communication and make us a stronger family. Having better communication leads to better patient care, better resident care, better outcomes. Don't forget, we're all a family. Hang on a minute. It's my Gardens family. Hi, Gardens family. Wonderful. Thank you for asking. That's how we communicate at the Gardens. It's a beautiful day in the Gardens neighborhood. Won't you be our neighbor? That's it.
Hi, I'm Steve Christina. I'm the dietary manager at the Gardens. I'm going to talk to you about cleanliness today and some kitchen do's and don'ts. Wearing a hairnet, that's a do. Blue bandage if you have a boo-boo at all. I mean, there is no blue food, so this is a good identifier. What we got hit with is cleanliness of fans, and this is, well, on some days this is my biggest fan because I'm in food service. So, ha ha ha. I know. The thing we need to pay attention to is you take the cover off the fan, and you've got to clean the blades. As you can see, this kind of stuff builds up. So you have to clean this very carefully. This whole thing will come apart. We can run it through the dishwasher. We can hose it off. But we have to make sure that this is really clean, because when we deliver food, what do? We cover the food. So when the fan is going around, it's blowing air all over. Whatever's in that air is going all over the food as well. So we got to make sure that these blades are really clean. It's kind of disgusting if you think about what's actually in the air, what's kind of gathers onto these blade fans. So rule of thumb is just, I have cleaning lists. Sorry. I have cleaning lists. The things that we needed to pay attention to are highlighted here, and we're doing those on a weekly basis. That's it.
Hi, well, my name is Joanne Skinner, and I work in the Quality Support Department. And so I want to talk today about one of the things that the surveyors observed when we were being surveyed was they noted that we were not providing preventative skin care to prevent the cause of pressure ulcers, and we were not repositioning and doing following our plan of care to prevent a pressure ulcer from becoming worse. So that was our really big tag, and so we've done a lot of education. Many of you have already heard about it. The major things they noticed is that we were not turning and repositioning every 2 to 3 hours as we are supposed to do by a standard of care. We didn't have redistribution cushions for pressure relief in our wheelchairs and our jerry chairs. We didn't float heels. Everybody knows what that means, keeping the heels up off the bed. We weren't timely providing incontinence care to our residents, again, every 2 to 3 hours and as needed. So our immediate action plan has been lots of education. We've already done a lot of education. It's ongoing. We're making sure that everyone is on the same page. Everybody's very clear of what our expectations are. And these are really standards of nursing practice across the nation. So we've really not recreated the wheel. It's the things that we all know. We just have to remember to get them done. We've had a special focus on how do we identify high-risk residents. So every single one of you can walk down the hall, and I really don't have to tell you who your high-risk folks are, who's at risk for developing a pressure ulcer. We've spent a lot of time talking about identifying those folks and then monitoring them more closely, paying really close attention to what we do with those people every day, how often we look at them, making sure they're the folks that are turned and repositioned timely to prevent the skin issues, because we want to have skin management, not wound management. That is our goal. Skin management, meaning keeping my skin healthy, not wound management. So we're going to focus, and you are going to focus as a team. We're all focusing on turning and repositioning, floating our heels, incontinence care. Think about taking our residents and laying them down after lunch. So when we get them out of their wheelchair, we give them pressure redistribution and relief on their pressure points. Watch for sliding in wheelchairs, sliding in bed. Those things are very damaging to the skin. Everyone needs to be aware, and it doesn't take a nurse or an aide to know that I slide in my chair, and every time you walk down, I'm slid down in my chair. That causes damage to the skin. Report that up to your nurse. If you don't feel like you're getting any feedback on the floor, talk to Riz, talk to Don. Don's not a nurse, but he can help us take care of that. So it is a team effort. It's everybody's responsibility. If someone's in activities for a whole day somewhere, we've got to bring them back and have them changed and then take them back to the activity room. So as a team, we can get this done and we can prevent the pressure ulcers. So the second thing that they had identified for us was some lack of documentation. So we were not consistently completing our head-to-toe skin assessments. Our action plan with that is we're going to do them and track them and monitor them at least twice a week. We were not doing our risk assessments, so everybody knows about our Braden score, and we've had a lot of education on how to use that and how to take an individual problem. If the only thing I have wrong with me is immobility, then I need a plan for immobility. And we know we're stressing that immobility is the #1 risk factor for pressure ulcers. The other thing that we struggled with was completing our MARS and TARS. We had holes in the TARs, as we all say. A hole in the TAR means the treatment wasn't done. If a wound gets worse, it indicates that we're not doing what we're supposed to be doing. So we have to complete our documentation. The other issue is that when we find an initial wound investigation, and when we find an initial wound, we have a couple of different processes that we follow, and it's very important that we do that, and we found that we weren't completing our documentation appropriately. So the first was if I find a wound or a skin tear, there is a specific log that's called bruise, skin tear, abrasion, rash, progress report. So that is the report that the unit nurse that finds the wound measures it, documents it, notifies the physician, gets an order, does the treatment, makes sure the right interventions are in place, notifies the family always, puts it in our care, and does the investigation in our care. That's very important. The second concern was that when we identified ulcers that were possibly pressure ulcers, there's a different form that we fill out, and that's called the initial ulcer progress report. So not a skin tear, not a clear skin tear, but a wound. If you're not sure what it is, you do the measurement, you get the order. Again, they're standing orders. You make sure that you match what you see as a nurse, so this is a nurse, what I see in the wound into the order that I choose from Centricity. That's very important. If I'm not sure, I called my friend Dr. Coleman, who's gonna help me get the right order. If I'm struggling, or I can ask my manager, but we definitely wanna get the orders that match the treatments, so we're providing the best care at the Gardens that we possibly can. The third concern was for an infection control issue during treatments, and that had to do a lot with cleansing of the surfaces before we set up to do a dressing change and hand washing. So we all know every time you take off your gloves, you wash your hands. If you can't wash your hands, you use sanitizer. I know that Loretta's going to speak to hand washing. We know with sanitizer, you continue until your hands are dry. With soap and water, I'll just mention things like, don't you turn when you go to turn the spigot off, you get a dry paper towel. You dry your hands first, then you get another dry paper towel, thinking that you touch the spigot with your dirty hand. So we want to be careful of those things. And hand washing, again, is every single person in the building. Every single person at some point probably puts on a pair of gloves. So no gloves in the hall for anybody. It's just a standard rule, no gloves in the hall. That would be an infection control issue, and we're not going to have any of those when we have our revisit in the first couple of weeks of April. So I think for me, it's just our action plan has been everybody is on the team. Even though pressure ulcers, they go, well, that's nursing. It's really everybody. Everybody can have a part. Turning and repositioning, providing the right pressure ulcer relieving devices, doing our skin assessments, doing our risk assessments, implementing the right plan for all of our residents. Infection control every day, every time. When we don't follow those, hand washing, we risk giving our residents an infection, and we're not going to do that. That is not our goal at the Gardens. Completing all of our documentation. And I do believe as a team, we can prevent pressure ulcers. So thank you.
Good morning. My name is Nasa Bala, and I am with the Quality Support Team. The two things I wanted to speak to you guys about today was the lab order procedure and also the transcribing of verbal orders, more specifically your antipsychotic meds. When you get an order in Centricity from the provider, it is extremely important that you guys take the order off and fill out the lab requisition slip when you get it. As nurses, we get extremely busy, and to write it down and to think that we'll complete it later, it usually doesn't happen. So it's imperative that we complete the lab requisition slip when we get the order for that lab. It's also important that we do not use stat stickers to place on the lab requisition form. The forms are carbon copied, so if you place that lab sticker on the front copy, 9 times out of 10 it's not going to be seen through the other 2 copies. The lab requisition form has 3 copies to it. The top copy goes into your lab book, and each unit has a purple lab book on their unit. So the top copy goes in here, and that kind of lets our lab techs know when we're supposed to draw that lab. The lab books are organized to where they have the month to when the lab is supposed to be drawn in the back, and then they also have numbers in the front. So your labs that are drawn for a specific month will be on a certain sheet. So it's important that when we take that order off that we file that lab requisition slip appropriately in this book up under the month that is supposed to be drawn. The yellow copy, the canary copy of the lab requisition form, goes to your nurse manager because they also have a way in which they track the labs. Your final copy goes into your patient's medical record under the lab section, and when that original order comes back, we then take that carbon copy out and we place that original lab into the chart. It is also important that we fill out this lab tracking form anytime we get an order for a lab. This form has several different columns on it, but the first one starts with making sure that we put the date that the lab is to be drawn here. Then we put the resident's name, and we put the date that it's ordered, and we also put the lab that's ordered. When that tech comes in to draw that lab, she also has a section that she needs to sign here stating that she drew that lab. And that's a piece that's really important so that when someone's looking at the sheet, that they are aware that that lab has already been drawn. It also has several other sections that go into making sure that the ICD-10 code is correct, and also documenting on here when that lab comes back, when that provider is made aware of that lab, and when that lab is then placed into that patient's medical record. If for some reason we are unable to obtain a lab, it is important that we let that provider know, let that supervisor know, so that we can reschedule that lab to be drawn on another day. The second thing I wanted to talk about was the transcription of verbal orders, and more specifically, your antipsychotic meds. It is important that when we get a verbal order from a provider of any kind, that we make sure that we understand that order correctly. As Dr. Coleman said, if we don't understand something, make sure that we ask for clarification. If we don't know how to spell it, it's okay to ask. If the provider spoke too rapidly, it's okay to ask them to repeat it so that you can make sure that you are transcribing that order correctly. If the provider is able to write themselves, it's always important that we encourage them to do so. It kind of cuts down on the errors if that provider can write that order for us. If they can't, we log into Centricity, we transcribe that order as they've given it to us. We also want to make sure that we flag the desktop. This is the only way that that order is going to come off on that end of shift report, so we want to make sure that we follow through with that step, even though we're the nurse putting that order in. We want to make sure that we note the order, that we print the order off, and also that we fax that order to Centricity. We all know that that we fax it to Remedy. We all know that Centricity and Remedy don't speak to one another, so it's important that we close out that communication for them. We also want to make sure that we transcribe that order on the MAR. And if that is an order for an antipsychotic med, it is imperative that we get the targeted behaviors that are the reason why that med is transcribed when we get that order. Once we put that order onto the MAR, we want to take it and place that order into the chart. In reviewing records when we were doing survey, we saw very good nurses' notes where the nurses had written where they had received the order from the physician, what the order was for, but when we went to look for that order in that chart, it wasn't there. So that's a very important piece, that when we get that order, that we place that order into that chart. If at any time we get an order for an antipsychotic, whether it's a new antipsychotic or a change in dose, it is important that we fill out an Ames test. And as you guys know, that we monitor the targeted behaviors for 14 days after we get the order for the antipsychotic meds. So it's important that on that targeted behavior flow sheet that we fill out what those targeted behaviors are and that we have that readily available for other staff to document on every shift. That's it.
Hi, my name is Misty Stevens. I'm the Assistant Director of Nurses at the Gardens for the Skilled Services. I have 2 topics that I need to discuss today. One is sliding scale insulin orders, and the other one is something that Joanne touched on, and that's holes in our MARS and our TARS. So the sliding scale insulin orders, we discovered that we had an issue when the surveyors came through. It was something that we actually were not aware of. They found it with no problem though, jumped right on it. We had an order for a patient to receive, the order read that if the blood sugar was between 250 and 300, to give the patient 4 units of insulin. And then it also said if it's between 300 and 350 to give 6 units of insulin. So the question arises that if the patient has a blood sugar of 300, on the dot 300, what do they get? So we had conflicting orders there. Again, they zoomed right in on it, and the patient had never had a blood sugar of 300, so it wasn't something that any of us had noticed. We say that with all new admissions and all new insulin orders, there should be a hard stop. And by a hard stop, I mean that 2 nurses need to stop what they're doing, look at the orders, check the MAR, check the order, make sure that it's written right, that there's no questions as far as how it's written, and then also make sure that it's transcribed properly as well. This order came through before we actually instituted that new policy or that new way of doing things, so it was missed. The other thing that in keeping on the insulin orders, we did talk about the hypoglycemia policy, and it reads that if a patient has a blood glucose for less than 70 and is unresponsive, you are to notify the provider, or if the patient has 2 blood glucose values less than 70, even after treatment with 15 grams of carbohydrate each time. We tell you now, we know that you don't just put sugar in orange juice or give them a quick high, because then it's a quick low as well. So their blood sugar will rise, but it'll drop again very quickly. 15 grams of carbohydrates is not a lot. It's a teaspoon of peanut butter. It's 2 like peanut butter crackers, a little small carton of milk, something that's more sustaining, half a sandwich. We probably give them, when we load them up, we probably give them a whole tray. So we're giving them like 60 probably plus grams of carbohydrates, but more is better. Our goal is to get the blood sugar up and keep it up versus up and then down. So the hyperglycemia policy says that we must notify a provider if the blood sugar is greater than 300 for 2 consecutive days. The exception to that rule is if it's better. So if you've had a blood sugar 600, now 300, then obviously the provider is aware we have an issue with blood sugars, and we would not have to call them based on that 300 at that point. The only other exception to that is if the provider has specifically ordered a sliding scale or different parameters for that particular patient. So the MAR-TAR documentation accuracy is an issue. The holes in the MARS and the TARS, like Joanne touched upon, is a problem. It's not only a problem that it's not being completed, but even more worrisome is a problem that we're not carrying out physician orders. We're not taking care of the patients, or we're not giving them the medications or providing the treatments that we need to be doing. And quite simply, that's a negligent act within that nursing practice. So if I'm a nurse and I'm taking care of your mother, then the expectation is that I give your mother all her medications and I provide her with all the treatments that need to be done. And if that's not completed, then I have to provide an explanation as to why. So often we see that it's circled on the MAR, which means not done, but no explanation. So when you go to court 10 years later, there's absolutely no way you're going to remember why you didn't give so-and-so's mom her antibiotics or whatever you didn't do. So we have, again, tried to institute another best practice policy, and that's that each nurse has somebody checking behind them. So when I come in to take care of patients and I get my patient assignment, my job, very first thing I'm supposed to do is check the MARS and TARS for holes. And then if I find any, I hold you accountable. So if you're trying to leave the end of your shift, you're actually not going to leave until you fix your holes. You either say why you didn't give it with the explanation on the back, or you fill it out that you did give it because maybe you forgot or you just missed it. We have given the permission for nurses, oncoming nurses, to not take over the cart, to not count, to not take report, to They have the right to refuse to do that if you have not filled in your holes in your Mars and TARS. And when we're doing our audits and we're seeing the holes still there, then not only is the person who left the hole responsible, but the one who followed them as well. And so that's just a warning to every nurse that if you allow the nurse in front of you to leave when she still has holes in her Mars and TARS, then you actually are going to be held just as responsible as that nurse, because we have told you, do not take the cart, do not take the keys, make sure they fix their holes. Verbal, written counselings, things of that nature will go on at that point. There is a form that's in the front of each MAR and TAR. All nurses are familiar with this, and it's where you actually sign that I checked your MAR and that you had no holes, and vice versa. So ongoing, oncoming, offgoing, all have to sign this form. And that's all.
Hi, I'm Sarissa Atkins. I work with Information Systems, and I am the support resource to the Gardens on their electronic health record Centricity. And the topic that I'm going to be covering is the end of shift report that nursing has to run at the end of every shift. We provided hands-on training to all of the nurses that came through the skills fair, making sure that they understood the importance of running this report, and to also make sure they actually knew how to access the report, how to print it, and what they were supposed to be doing with the report. So this report is really a checks and balances against the orders that make it to the paper chart. So the report populates all orders that have taken place in the building in a 24-hour period. Those reports are then ran and printed, and nursing takes this report and checks it against the orders that are actually in the paper chart. One hole that was realized is that a lot of times if they found an order on the report, they weren't going through to the next step, which was to then print the order, make sure it got faxed to Remedy, and transfer it to your MAR and TAR. So we reiterated the importance of when you do find an extra order on the report and you do not find it in your paper chart, that you still have to go through and do those steps. You can't just assume that those steps were taken care of already. So that was a good training point for nursing. We also went through and showed nursing how to save this report as a favorite in Centricity. This will help save them time. It cuts out a few steps that they normally were going through and doing. So we're hoping by saving them some time and educating them on what to do in the event that orders are not in a paper chart, that we have helped them. We also have gone through and restructured some of our orientation training so that this report will be an important reference, that we will make sure that we're spending more time going through why it's important that this gets run every shift. And also, if you do run across an order that's on the report, it's not in your paper chart, but as a nurse, you're having trouble clarifying what the order is, that you needed to follow up with the provider that gave that order and/or check with the nursing supervisor for clarification if you did have questions about the order. We also created a new training handout. This is now available on every unit for nurses, as well as it will be given to all new employees when they come through orientation at the Gardens, so they will have a reference to keep on them of how to run this report. So thank you very much. I think I had the shortest portion, but thank you so much.
Hi, my name is Damika Yarber. I'm the nurse mentor on the Monticello unit at the Gardens of Warwick Forest. Today I'm going to be talking about care of your hemodialysis patients. Just a quick background. We don't have many hemodialysis patients at the Gardens, but it is important for us as nurses to know how to manage complications and the risks involved with hemodialysis. As we know, hemodialysis is a treatment for mostly end-stage renal disease. It can be permanent or temporary. Your main job as a nurse here at the Gardens is to know how to identify complications and manage the access sites used for dialysis. You do need to know what days your patient goes to dialysis, where they go to dialysis, and of course what time they need to be there. Your main responsibility will be to maintain their access site for dialysis. And there are two types of access sites that we see in hemodialysis patients. The most common would be an AV fistula, It's a surgically implanted connection between a vein or artery, usually in one of your arms. When your patient returns from dialysis, sometimes you may see nothing there. There may be a small Band-Aid there. You should leave that on for 24 hours. What you will need to do on a daily basis to care for that access site is to, of course, assess it for signs and symptoms of infection. Any pain, tenderness, purulent drainage from the site needs to be reported immediately. And you also want to assess for patency of the AV fistula. We do this by checking for a bruit or a thrill. Most nurses have learned to feel for the thrill, so you basically palpate the site and you should feel a small vibration there. That ensures you that the blood is still flowing. You also want to listen with your stethoscope for a bruit, and you should hear a slight swooshing sound, and that will basically confirm that you probably have some pretty good blood flow in that access device. If you cannot feel the thrill or listen to the bruit, you want to notify a physician immediately. This could mean that the shunt is clotted off or there's a problem with the access. The other type of access that we sometimes see, not as common, is what we call a permacath or a subclavian catheter, normally in one side of your chest. When a patient goes to dialysis, the dialysis nurses will take care of the dressing changes. They'll also flush and maintain that line. Our responsibility is to often check the insertion site, make sure there's no redness, no warmth, no purulent drainage or other signs and symptoms of infection there. If you see anything, by all means, you can come get one of your nurse mentors or notify the physician. Some other important things to remember: if your patient does have an implanted AV fistula, you don't want to take blood pressures in that arm. You want to remind the lab technicians not to draw blood in that arm. As a nurse, you also want to make sure that none of your patients' medications are scheduled when they're out at dialysis, because we want them to still get their medicine. You also want to know if they're on fluid restrictions, because sometimes they can only have a certain amount of fluids in a 24-hour period. You also want to make sure that they're getting an appropriate renal diet. And if you have any questions about that, you can also come to one of us, the nurse mentors, or one of the dietary personnel. They're usually very knowledgeable about that. So the main thing, I challenge all the nursing staff to, number one, know who your dialysis patients are, and number two, be comfortable with what type of access that they have and know how to monitor that while we're here. Thank you.
It's Christine, the assistant administrator, back, and I'm back to talk about weekly weights and how we manage those and how we use those. We had a deficiency in which we had an order for weekly weights on a resident, and we were not getting that weekly weight for the resident. So we've made some changes to how we handle weekly weights. The first one being that we DC'd all of the orders for weekly weights. Now, that doesn't mean that we're not taking weekly weights on anyone anymore. It just means that we're not having an order for it. The list of weekly weights will come from the Standards of Care meeting and the IDT team, and they will determine who needs to be on weekly weights. And there are a number of reasons that we would monitor a resident's weight weekly. It might be because they have low intake on their diet and they don't eat very much, and we want to keep an eye and make sure they're not losing weight. It could be because of a disease process, maybe CHF or another that allows the patient or resident to build up fluid, and we want to monitor that. So weekly weights are very important, and just like anything, we don't want to not do a physician order, but we want to make sure that we're following our protocols and our procedures for everything that we have. So the team of restorative aides that take weights will get a list each week with those that they need to have for weekly weights and those for monthly weights.
Hi, my name is Cynthia Lee. I'm an RN nurse mentor from Riverside Healthy Living Community in Smithfield. I have been asked to come over and assist you with your post-survey training. And the topic I want to talk about today is managing common complications of the PEG tube, as well as guidelines for CNAs that are caring for residents with PEG tubes. Okay? One of the most common complications I think most nurses come across with residents that have PEG tubes is a blocked tube. During our training, I think every one of the nurses did testify that yes, they have come across that complication. So what you want to do in case of a blocked PEG tube is you want to first attempt to gently flush the PEG tube with warm water. If that does not work, policy says that we can attempt to gently flush the PEG tube with a carbonated beverage, preferably ginger ale. And if that does not work, then of course we want to notify the provider for further instructions, and she may want to have the PEG tube replaced. Okay? To prevent PEG tube from becoming blocked, it is very important that the nurse would follow the treatment orders to prevent blockage by flushing the PEG tube with 30 cc's of water before and after each use. A lot of times residents will receive multiple medications, and it's very important that they administer one medication at a time. So you would provide 30 cc's of water before, administer the medication, followed by 5 cc's of water in between each medication, and then follow up with 30 cc's of water after that. If they go in and they find that the PEG tube has become dislodged, you want to cover the PEG tube site with clean gauze. You will notify the provider right away as soon as possible, and the provider may give you instructions to reinsert the PEG tube as soon as possible. So as a CNA, when they go in to provide care to residents with PEG tubes, they want to do a lot of observation. While they're in there providing care, they want to look for signs and symptoms of aspiration, such as choking, gagging, or the residents clutching their throat. They always want to make sure that when the tube feeding is on, that the head of the bed is positioned and elevated from 30 to 45 degrees at all times. They always want to follow fluid orders. Most of the time, residents that have PEG tubes have an order for NPO. And with NPO comes the complication of you might get dryness, sores in their mouth, so it's very important that they provide good oral care, and they are not to provide anything to that resident by mouth. They don't want to pull or tug on the PEG tube when they are turning and repositioning or transferring that resident. It's very important, as well as making sure that the tube feeding tube that is connected to the PEG tube site is not kinked or underneath the resident when they are finished providing their care. And anytime that the CNA will go in and provide care to these residents, they want to observe for a lot of those complications, they want to notify the nurse immediately. For example, if they notice any cyanosis, resident has complications like shortness of breath, nausea, vomiting, complaining of cramping, any signs of aspiration, they're pulling at the tube, things like that. The alarm might be sounding off, the bag might be empty. They might go in to provide care and the PEG tube and the tube feeding tube are disconnected. There might be tube feeding. It is very important that they notify the nurse of any of those observations that may occur. So again, this is a team effort, and we ask that all departments, whenever you are around any of the residents that you know have a PEG tube and you notice any signs and symptoms of shortness of breath, or the tube may be out, or an alarm sounding, please notify your nurse, as soon as possible, so that we can manage these complications very well. Okay, that's all I have. Thank you. I'll turn it over to the next speaker. I believe that's Loretta.
Hi, my name is Loretta Lovelace. I'm the Assistant Director of Nurses for Quality Initiatives at the Gardens of Workforce. I want to talk about hand washing and our policy. It is our policy that hand washing be regarded as the single most important means of preventing the spread of infections. All employees should follow hand washing policies and procedures to prevent the spread of infection and diseases to residents, visitors, and other employees. Hand washing facilities are readily available throughout the facility, and also alcohol-based antiseptic hand cleanser Purell is available for the staff. Dietary employees' hands must be washed at the kitchen sink upon re-entry into the kitchen area. Hands must be washed after removing gloves. Some other instances where hands must be washed is before and after work shift. So when you come to work, wash your hands. When you're leaving, wash your hands. Before and after each procedure. Joanne Skinner spoke about that. Before and after any physical contact with the resident, after removing gloves, gowns, or masks, before serving food, before or after you give medications, after you use the toilet, if you sneeze or blow your nose. When your hands become visibly dirty or soiled, you need to immediately go wash your hands. Before you eat or drink, make sure you wash your hands. When in doubt, wash your hands. When the surveyors are here, make sure you're washing your hands just like you should at all times, because they're going to be observing you for that. Hands must be washed for the minimum of 20 seconds. You can always go longer than that if needed. We have a handout on how to wash your hands that goes over the procedure with that. Another thing that we do at the Gardens is we have a program called the Secret Shopper. And we have secret shoppers on all 3 shifts that will be watching you to see if you're washing your hands. And they turn in this data to me, and I collect that each month. Our goal is that we will be 100% that people will be washing their hands. If you're not washing your hands the correct way, you will be given a hand hygiene violation form. And this form is, you're receiving this letter because a secret shopper has caught you dirty-handed. That means you did not wash your hands or use hand sanitizer when appropriate. The purpose of the hand hygiene program is to prevent healthcare-associated infections. One of the things, I monitor infection control here in the building, and if we see people are not washing their hands, we monitor that. Like I said, they get this form, they have to sign it, and also I map out each facility, each unit, where the healthcare-associated infections. I have each one of these for each of the units. We have 200, 300, Monticello, Piedmont, and the Chesapeake, and I monitor whether the infections, healthcare-associated infections are on a certain unit, what residents' rooms, and then we go back and I can do some patterns and trends, and we can look at the staff, if possibly if they're not washing their hands, but if it's the same organism that's spreading from one resident to another. So it's so important that you wash your hands. And I want to thank you for washing your hands.
Hi, I'm Angela Barnes, the Director of Facilities, and I brought Ron Brown, my maintenance tech, to help us talk about work orders and wheelchairs and lifts. Hey Ron, don't forget, Piedmont 7 has a light out.
Did you call in on a work order?
Hey Ron, I also have 523 beds broken.
I need a work order on that.
Hey Ron, I have a problem with the heat and we have 300.
I said I need a work order on that.
Somebody call for a work order. Who called for a work order? I'm here. Hey, my name is Work Order, and my twin's name is Job Done. How y'all doing this evening? What you doing?
I'm working on a wheelchair here, and could you please explain to her how this works? Because she's giving me a honey-do list. And we're not even married.
You're not married, and she's asking you to do all this?
Yes, she is.
You folks need to excuse my English, because I was just created a couple of months ago, and I'm trying to get a handle on this healthcare language that you folks use. I'm just so confused, but you know, after I was created, I was waiting for someone to call me. No one has called me. Today, though, I got a call from Miss Facility. Are you Miss Facility?
Yes, I am.
Hello, Miss Facility. How are you doing?
Good.
Good. Well, then you must be responsible for all these words that I have attached to me.
Yes, I am.
Well. Well, let's see. This one says that in room 507, that you spoke with Maria in social services. Well, isn't that something? So, social services, puts in work orders?
Yes, it is.
Oh, that is just amazing. I love that. And this one was put in by somebody named Arthur. Arthur wants the TV reset. Well, that is just wonderful. I love that. I love that. You know, on my way in, I found this wheelchair. It was just sitting in the hallway. It called my name. It said, work order! Work order! I came on over. I wanted to see just what was going on. Now, can you imagine? I was walking through the halls of the gardens at Warwick Forest. I saw this amazing sign. It said that we care for others as we care for those we love. So I got confused, facility. And the reason why I got confused is because of this here wheelchair. Can I show you? Can I just show you what I'm talking about? Well, imagine my surprise when we said that we care for others as though we care for those we love, and this is what I found. Now, can I just be honest, facility?
Yes, you can.
This chair doesn't look much like we love the person that sits in it, correct?
That's correct.
Now, you know, facility, and how you doing, Screwdriver? I'm so sorry I didn't introduce myself. My name is Work Order.
Nice meeting you, Work Order.
Do you know that someone's mommy and daddy's behind sits in this chair?
Yes.
Now, we're not showing a whole lot of love if this is how we have this chair, correct?
Correct.
I just don't know, but you know what? My name is what?
Work order.
Work order, and my twin's name is what? Job done. So we're going to get this job done. We're just going to take my little friend. This is my cousin Virex. I just wanted to introduce that to everybody. And Virex is a disinfecting quaternary cleaner. Do you know it cleans just about everything? But you know Virex has a sweet, sweet cousin. And his sweet, sweet cousin's name is Bleach Germicidal Wipes. And we have these throughout the entire facility at the garden. So there's really no reason why anybody's behind should have to sit in this chair.
Correct.
So we're just going to go about, and what you do with the Virex, if I can just have a moment. Do I have a moment? I have a moment. Well, thank you very much. We do 3 squirts. We do 1, we do 2, and we do 3. And then we just proceed to wipe the area just as nice. And you know what's so nice about this is when we're all done, because we all work together, cousin, oh, you didn't tell me, facility. You always have to have your gloves on when you're cleaning because you just don't know what you're going to come up against. So we got to have our little gloves on. Please forgive me. But my little cousin Bleach, we just going to come in here, we're going to get one of these, and we're going to follow this up with Bleach. Because they're 2 cousins, Virex and Bleach. You will never see one without the other. They go hand in hand all the time. Well, I tell you, I'm just so pleased with what we're doing here today. And you know, these folks at the gardens, you know, we're family. And we said that we were going to be kind to people and we were going to help them heal. Now, I don't know how a broke down, taped up, crusty looking wheelchair is going to help anybody heal. It certainly doesn't show that we are kind to them. So what we're going to do today is we're going to get everybody in the facility to help us out. Do you know what kind of things that people can call me for?
Yes, I do.
Well, go ahead and tell these good people what kind of things we can call people for.
Well, we can call people for if the light is out, if we have a broken call bell, if you find a dresser is wobbly and broken and uneven, put in a work order for it so we can fix it. If you see somebody's bed is broken or if something's not working right, call it in a work order. I mean, we have the front desk and we have protection. You can call them directly and they will put in the work orders for you. So please call the front desk from 8 to 8. Call protection from 8 to 8 in the morning. So please call him to get a work order in so Ron can fix the chairs and he's not chasing me down the hallway when I yell out down the hallway, Ron, P-7 light out. Because he will get busy and he'll forget, I will get busy and I will forget.
Well, Facility, I think you got a hold of what you healthcare people call a concept. That is just a wonderful idea. I see us all working side by side. We can get things looking real good around here, but it's going to take everybody. You know, on my way here, I ran into a very good friend of mine. His name is John Maxwell. And John Maxwell and I have got to be good friends through the years. And John Maxwell says this, that teamwork makes the dream work. Thank you, folks. My name is Jacqueline Ellis. I'm the campus director